Living Well, a show about the mental, physical, financial, and social determinants of well-being. I'm your host, Mark Hennick. The decisions that governments make deeply impact almost every aspect of your well-being, in big ways and in small ways. How we construct our social supports as a society and the standards of care we set, these can be major determinants in whether, how, and where people get help for a variety of issues. So today, we're going to dive a bit deeper into the policies and decisions that impact our well-being, and in particular our mental health. I'm going to be speaking with Amy Kennedy. She's the Education Director for the Kennedy Forum, along with Ben Miller, President of the Wellbeing Trust. Later, I'm going to talk with my old friend Michel Rodrigue, President and CEO of the Mental Health Commission of Canada. But first, Mary Giliberti is the Executive Vice President of Policy at Mental Health America. Before joining MHA just a few years ago, she was the CEO of the National Alliance on Mental Illness, NAMI. I tapped into Mary's many years of policy and advocacy experience in the social movement of mental health to get a sense of the state of affairs in America today. So here's my conversation with Mary Giliberti, Executive Vice President at Mental Health America. Now, for our listeners who might not be completely familiar with how the policy space and the mental health space intersect, can you give me a little bit of a crash course in how that happens? Why is government policy relevant to the lives of people with mental illnesses?
Oh my goodness. Government policy dictates how we pay for mental health services, what kinds of things we have to do, what kind of quality we get in our mental health services. So mental health policy drives a lot of what we see or don't see, as the case may be, when we're trying to access mental health services out there.
Now, what are some of the key policy issues that impact people with mental health problems and illnesses? I assume, of course, it's not only healthcare related. There's a wide range of policy issues, right?
Oh, for sure. There's issues like employment, housing, all kind of education. Every area touches mental health, right? So it's not just mental health and health, but it's all these other areas as well. So there's a lot to do in mental health policy.
There certainly is. Now, of course, we have jurisdictional issues in mental health policy, too. Here in Canada, where I'm based, healthcare is provincially delivered, but there's also federal involvement as well. And you, over at Mental Health America, you focus on federal policy in particular. So how do you navigate that, the differences between federal policy versus state and even local policy?
That's a great question. I think they're very linked together. So I think when policy's done well, those things link very well. So you have states, there are laboratories. People try out policies at the state level and we see how they do, particularly if we can measure some outcomes. And then if we see that the state policy is a good one and more states adopt it, then we get federal policy. And vice versa. Sometimes federal policy will set the standards and then the states will change within that. So Medicaid's a good example of that. In Medicaid, it's a federal state program. So the Fed sets some parameters, but then the states get to make a whole lot of decisions. So state and federal really get very much linked together. Mental health parity, which is like treating mental health the same as physical health by insurance companies. We all know how that used to be. You used to only be able to get like 20 visits if it was mental health, and you could get as many as you wanted for other things. Those things don't happen anymore. Of course, we all know we don't have true parity. We can talk about that later. But the states passed those bills first, and then we got some federal legislation. Then we got better state policies. We got more federal legislation, and that cycle keeps continuing. So I look at states as laboratories for good ideas that I can pull up to the federal level. And part of my job is to work on federal policy and then tell my state affiliates what they can do with that policy to make it even better at the state level.
One of the issues that I've noticed up here in Canada is that we have something called the Canada Health Act, which is supposed to level the playing field across province to province in terms of how healthcare is delivered, specifically mental health care. However, even with that federal legislation, you still see wildly unequal service delivery systems. If you live in a major metropolitan area, your service is going to be very different versus if you live in a rural area or a province that has less resources. Do you see similar inequities based on geography across the United States as well, both in terms of service availability, but also in terms of funding or type of services available or quality of services available from coast to coast?
We see tremendous variability. And as I mentioned, Medicaid is a state-federal program, so states can make a lot of decisions that affect what you can receive, that affect reimbursement. So you'll see a lot of variation state to state. We saw with telehealth, for example, states had that ability to make some choices during the pandemic, and some chose to be expansive and some chose not to. And that's the case in many areas of mental health policy. So yes, absolutely, we see variability all the time in services and supports. And it's very difficult for people who are out there looking for help to know what's out there. That's a big problem in mental health in the United States. Just navigating to services and supports. So many times families and individuals who have these conditions don't know where to go, where they can get help, because it's so fragmented at the local levels. And our private insurance companies don't pay for certain services that you might want. A good example of that is something that MHA works on a lot, which is peer support services. So that's when someone who has a lived experience with mental health or substance use helps somebody else who is having those conditions. And private insurance doesn't cover that. Medicare doesn't cover it. Medicaid does cover it, but pays really poorly. So again, leading to some places where you can get it, some places you can't, and lots of variability.
One of the things I think that has become abundantly clear over the last 18 months of the pandemic has been the requirement for, or the necessity, I think, of portability of professionals to be able to work in different states, especially with telehealth, right? So what does that look like in the United States? Can we equalize the playing field for professionals who might want to practice in different areas?
That is such an important question, and it's something that is very frustrating, I think, to many of us who are helping people try to find services. So we still have state licensure rules that make it very difficult, even for joining states, even for states that are very rural and could use help from another state, for services, mental health services, to flow over those state lines. It's hard for college students. It's hard for everybody, and yet these things still persist. Many of us have been arguing for a lot of time that the state licensure should run to where the patient is, the person receiving the services is, not necessarily the provider. But unfortunately, it runs often to where I'm sorry, I mixed that up. It should run to where the provider is and not where the person is. So you shouldn't have to go to Maryland, for example, to be able to see a Maryland person. You should be able to stay in Virginia if you want to and see somebody in Maryland. It shouldn't mean that your body has to go somewhere because of licensure laws.
Sure. And I mean, I guess the biggest benefit of that, of course, is that it gives you access to, for example, a New York City therapist, no matter where you live, right? If you live in a rural or remote area. Right.
Exactly. It would give you much more options if we didn't have all those restrictions. And, looking at how restrictive, how hard it is to get care, that's really where I'm coming from, is I look at how many people are desperately trying to find somebody, particularly covered by their insurance. I mean, that's a whole nother game here in the United States. You need somebody who's covered by your insurance in your network. And networks are, just not adequate for most places in this country. And we don't have mental health professionals in so many counties. No psychiatrist, child psychiatry. That's like looking for a needle in a haystack.
Mm-hmm. Now, one of the things that, we find here in Canada, I think, is that, we have more psychiatrists in Toronto than per capita than anywhere else in the rest of the country, which I don't think would surprise any Torontonian. But it also means, though, that, or what we see anyway, is that the number of professionals become more selective in the types of patients that they see or the amount that they practice. So it doesn't actually increase access very much either. So then, when we're looking at things like licensing and types of professionals who are available, we have here in Canada professionals standing on the sidelines, social workers, psychologists, psychotherapists, who don't necessarily have the right to practice or to get to receive compensation at all. Do you see something similar with your insurance providers and Medicaid, Medicare down there as well, in terms of who they're willing to reimburse and the types of services that they're willing to provide?
Oh, absolutely. I mean, Medicare, for example, that's our program for older Americans and people with disabilities, including mental health conditions. Marriage and family therapists are not covered. Peer support specialists are not covered. Crisis services are not covered. So that benefit is so outdated. It also includes a lifetime limit on bed days for mental health, which, again, you can't do that even in private insurance here in the United States, but Medicare does it. It's an old, antiquated benefit that needs to be updated for mental health, for sure.
Mary, I could talk to you all day, and I'm going to bring you back to do a little extra segment that our listeners and viewers can pull up after this episode. I want to talk to you more about your new report on youth, and I want to investigate a little bit more around policing and how people respond more effectively, how we can respond more effectively to that issue. So for this part of the show, I want to thank you for joining me. Mary Giliberti is the Executive Vice President of Policy for Mental Health America. Thanks again for joining me, Mary.
Thank you for having me.
We are always moving forward. In our changing world, there is an unchanging principle for success that inspires us. By improving a person's life, we'll improve how they perform at work. We are LifeWorks. We are the world's leading total well-being provider. We are innovators with tech-enabled solutions and one integrated platform. We have the scale of a large company with the agility of a startup. We are experts in our sector and are continually learning so that we continue to be valued and trusted partners. Our mission is to improve people's lives by supporting the whole person, their mental, financial, physical, and social well-being. We empower people to prioritize their well-being and help them with challenges at important moments in their lives. We believe this creates happy, healthy, and empowered people. These people are the heart of successful organizations, leading these organizations to a more resilient future and making a real difference in the world and in our communities. We are moving forward with purpose, improving lives, improving business. We are LifeWorks.
Welcome back to Living Well. I'm Mark Hennick. Continuing our conversation on how social policy issues impact well-being, I spoke with two more incredible advocates. Benjamin Miller is the president of the Wellbeing Trust, a national foundation dedicated to advancing a vision of a nation where everyone is well in mental, social, and spiritual health. Amy Kennedy is the education director for the Kennedy Forum, where she pursues partnerships that emphasize evidence-based research and programming to facilitate policy change in the areas of education and mental health. Ben, thank you so much for joining me today.
Yeah, it's good to see you, Mark. Thanks for having me on.
Amy, you as well. Thank you for making the time to talk with us.
Yeah, glad to be here.
Now, I want to go to you, Ben, first. I talked with Mary Giliberti about some of the various policy issues that are impacting the mental health of Americans every day. You know, everything we talked about, everything from policing to education to the transportability of credentials for professionals. But in your mind and in your work, what are some of the top two or three policy issues that are really impacting the mental health of Americans today?
Well, thanks, Mark, for the question. And I agree with Mary. This is a multifaceted and complex issue, but I'll take it in a little bit different direction since I anticipate, I think I know what she talked about. I think that what's really been impacting the mental health of our country have been things like job loss, loss of family members, the uncertainty that comes with not knowing if it's going to be safe to send your kids back to school. These are profound and I would say highly potent impacts on our mental health. While they're not necessarily policy issues per se, sometimes they could be, I guess, what we've seen is this reluctance to acknowledge that mental health has been impacted in major ways, far beyond just the inability to access a clinician or the inability to have health insurance that might cover the access to a clinician. So I think right now it's a moment for us to really reassess how deep we can go on policy and really think a little bit more about some of those community level conditions that do impact positively our mental health.
Now, the sponsor of our show, LifeWorks, has been doing monthly assessments of the impact that COVID-19 has had on not only Americans, but Canadians, Australians, and others throughout the world. So certainly, I mean, this has been talked about many times before, the impact that COVID-19 has been having on the mental health of our populations, but particularly when we're getting into this stage of it, approaching 2 years, the fear of another relapse into the symptoms of COVID again. You must be seeing this borne out in the data that you're gathering as well, right?
We have, but let me just kind of take a step back, because the problems that our country, at least here in the US, was facing prior to COVID was pretty substantial. I mean, we were losing more lives to preventable causes, things like drug, alcohol, and suicide in 2019 than we ever had before. So 2020 wasn't an easy year, and the data actually reflect that. If you look at drug overdose deaths, we saw 93,000 people lost their lives in that year. So 2021 could be worse. It could be better. I hope it's better. But I think that the underlying issue here is that the problems that most of America was facing that needed help with never got addressed prior to COVID. And COVID has uncovered some of those really pretty egregious structural issues and flaws that we have within our system, that if we really want to do something meaningful about the mental health of our nation, especially during COVID, we'll pay attention to those larger structural issues.
This is a really good point, Amy. I want to bring you on this one as well. Amy Kennedy is the education director for the Kennedy Forum. And of course, you and your husband established the Kennedy Forum well before COVID. So there were already structural issues that were happening. The foundation was already shaky. So tell me a bit about the Kennedy Forum and some of the work you were doing even prior to the pandemic.
That's right. Yeah, it's not new that we've seen mental health be kept separate from our physical health. And so while Patrick had been in Congress, he was the author of the Mental Health Parity and Addiction Equity Act. And after leaving, saw that it still was not being enforced. So while it was on the books, when you went and you wanted to get coverage for mental health, unfortunately, you saw that it was not on par with your physical health. And so we need to change that. And that means going state by state to make sure that it is enforced and that it's going to be covered in network, not phantom networks. There's a lot there that now we're seeing even trickle over, because as Ben mentioned, this was something that existed before. As a school teacher, I'm seeing it. It was not just the issues that the parents had, but kids would bring that into school with them as well. And so they're not able to get the coverage for the things they need, or parents are paying out of pocket for services now for their kids who are struggling with anxiety, with depression, the isolation that they've been through, the worry and stress that their families are going through is now really become a burden for the whole family.
No, I think we like to pat ourselves on the back and think that we've conquered stigma. There's so many celebrities and athletes and public figures speaking openly about it. But really, at its core, I don't think we have cracked the discrimination that happens in the mental health care system and the healthcare system more broadly when it concerns mental illness. So what does this lack of parity between mental health and the rest of the healthcare system, what does that actually look like in practice on the ground when somebody reaches out to their healthcare provider for help? How are they treated differently?
It's, I just mentioned in network, talking about that, but for somebody who's already in crisis, trying to find a provider and have that covered is so extremely difficult. So we're taking people who don't know where to turn, they're already at a crisis point, and making it even more complex because the insurance will not cover, or they don't reimburse in the same way for providers, and therefore there's fewer providers. So we're seeing it not only in the consumer that's struggling, but the providers who would otherwise want to cover these fields. There's the shortage, and now it's impacting our whole country. I live in South Jersey. And in South Jersey, we really have a provider desert. We're hearing all the time how there aren't enough psychiatrists, therapists, and especially when it comes to our youth, to handle now the influx of people who are seeking that kind of help. And that comes down to the system, as you mentioned. The system is built in a way that it doesn't reimburse for these services. Once that is adjusted, I think that we'll see more people being able to get into this field and stay in this field. But in the short term, we have an overwhelming number of people in emergency rooms because there simply aren't treatment beds available, because we're looking at a crisis not only of COVID, but through this pandemic, we've seen a crisis level of anxiety and stress, and people don't have somewhere to turn for that kind of help, and they can't afford to pay out of pocket.
Amy Kennedy is Education Director for the Kennedy Forum. Ben Miller is President of the Wellbeing Trust. You guys are going to hang around, and we're going to have a bit more of a conversation after this, if you don't mind.
Sounds good.
Sounds good.
Sounds good. Okay, good. So for those who are watching today or listening, because now we're both audio and video on Living Well, you'll be able to catch our bonus conversation. We're going to dive into a little bit more depth over on our YouTube page. So go check that out. In the meantime, Amy, Ben, thank you so much for joining me on Living Well.
Thanks, Mark.
Michel, thanks so much for joining me today.
A pleasure to join you today, Mark. It's been wonderful to see you again.
You as well. Michel and I had the privilege of working together at the Mental Health Commission when I was on the board of directors, and he was coming in at the time. And now, of course, you're CEO. So you have been for a little while, but congratulations on the promotion.
Thank you so much. It's quite a daunting task, but one that is humbling and an important role within Canada. So I'm really thrilled about that.
It certainly is. Now let me take actually to pick up on that a little bit. Take me a step back, since I introduced this in the context of a workplace mental health setting. But one of the notable things about the workplace mental health movement, I think, over the last decade or so, has been how inclusive it's been of a range of issues, right? That it's the mental health system, I think, in Canada is still very siloed, but we're more cognizant of the variety of policy considerations that play into mental health. So, all that said, particularly within the context of COVID, what in your mind are the top policy issues or concerns in Canada with respect to mental health?
So as you rightly pointed out, there are complex issues. And I think what's coming to the forefront currently is really the need to address the intersection between mental health and substance use at a national level. We've already seen provinces and territories, cities, taking really this challenge on. Just a reminder, people often have what we call concurrent disorders. For example, 24% of people with substance use disorders also have a mood or an anxiety disorder. And this is in the past year alone. We know because of research that 78% of people in treatment for substance use disorders also have had a psychiatric diagnosis at some point in their lives. So right now we're working with a disjointed model of care that is really not serving people very well. August 31st was International Overdose Awareness Day. And we know there's a very scary correlation between people who use opioids and the likelihood of them contemplating suicide plans. They're actually twice as likely to attempt suicide. So with that in mind, we need as a country to do better. and provide neat, unique pathways for care so people don't have to be bounced from one system to another. They don't have to have instances where they're told to sober up before they get mental health services or vice versa. So I think that's one of the major elements, and it has correlations within the workplace because workplaces are microcosm of society. So those are issues that we need to tackle and address within the workplace.
Now, I think that, certainly addictions and substance-related disorders have been treated, I think, historically quite separately from
Correct.
mental health problems and illnesses. So is that an evolution that you've seen, whether it's in workplace policies and HR policy, or just in government policy more generally and healthcare delivery? Is it a trend to see the two largely separate fields come together, mental health and addictions and substance-related disorders?
I hope it's a trend, honestly, Mark. I think it has been more holistically addressed, both issues together. The more we focus on patient-centered care or centered care, I think the more people will see that that's the way to move forward. The historical perspective has been quite a steep learning curve for me. To this day, there isn't a neat definition of what recovery looks like in terms of substance misuse or substance use and addiction. So that's an element that certainly has impacts. The way our systems are structured, they're completely disjointed. So I think moving forward, we really need to provide a national leadership on how to do this with best practice. I think another element, if we turn our attention to mental health, we knew that prior to the pandemic, approximately 1.6 million Canadians were reporting unmet needs for mental health care. That gap has only increased with the pandemic. So we really need to turn our attention from a policy perspective to more innovative solutions to care. We know we can't train human resources fast enough to respond to the need. So we need to be a bit smart about how we're going to tackle this problem. One of the promising approaches is providing the right level of care for the needs. Generally, it's called Step Care 2.0. And in a nutshell, it means providing the least intensive care really when you need it. So if someone's experiencing anxiety, they might begin with a self-guided app, for example, and then move up to seeing a counselor if that doesn't resolve the issue. So you can move up and down on the scale. And the highest level of care, of course, is working with a complement of healthcare professionals, including a psychiatrist.
Yeah.
Wonderful example of that is the Wellness Together Canada portal. It's based on that infrastructure. It was put in place by the federal government to support Canadians as we go through this god-awful pandemic. And it is based on that approach. So if any of your listeners at this point are experiencing issues, and unfortunately, a lot of us or a lot of them don't have services paid by the employer or the province, they can actually access that immediately.
I want to bring this issue back full circle to the National Standard for Psych Health and Safety in the Workplace, which I mentioned at the top of our segment. This was launched back in 2013, and I think uptake, it seemed from the outside, was reasonably good based on the business case for improving psychological health and safety in the workplace. But maybe can you tell me a bit more about that trajectory of uptake among businesses, and in particular, if you think the last year and a half has really brought along some of the holdouts for recognizing the importance of psych health and safety in the workplace, given the situation that we're all currently facing?
Rightly said. Wellness within the workplace preventing psychological harm has never been as present in workplaces, particularly since we have been dealing with this ongoing pandemic. So the trajectory has been as follows. Initial uptake has been very active, and we've continued to promote it. It continues to be the highest downloaded standard from CSA Group. So a lot of interest. A number of other countries have implemented the standard. It remains a voluntary standard, which provides under 13 psychological factors, a way for organizations to gauge where they are in terms of creating psychologically safe space for their employees. The pandemic has really changed our perspective in a lot of ways, because things that we thought would be decades in the doing happened overnight practically. We all moved from being in an office setting, for those of us who function in an office setting, and then started working from home virtually. We're fortunate we were able to continue to work and didn't have a pause in our work because of that. But this created a number of other challenges. I just look on our team. A lot of our team members were dealing with childcare issues, so they needed to tend to children while working. They have the challenges of working and supporting elderly parents, and they managed to do that without dropping a ball at the office. And what permitted them to do that was we needed to be adaptive and innovative. We adapted our schedule of work to allow for them to do their work and also be respectful of their family requirements, childcare requirement. And we are now starting to rethink what work should look like. So I suspect that the standard and the 13 psychological factors are bound to evolve as well, because the reality of workplaces is changing. If we take a step back, when I started at the commission, people knew about wearing a hard hat. They knew about keeping people safe physically within the workplace. We had workplace committees that did a tour of the office once a month to highlight and point any challenges to the physical wellness of employees. We did not have the same practices, policies in place to support or to prevent psychological harm. It is as important. So I think we are moving forward, and the impact on businesses, both on private and public sector organization, remains the same. There was a return on investment study done by Deloitte on the standards and its impact on workplaces last year. And it found that for organizations that had implemented the standard for 3 years or more, a median return on investment was of $2.18 for every dollar invested. So it's the right thing to do, and it's also the right thing to do for your bottom line or to be as productive as you want in the workplace. So I think it's been a wonderful learning experiment for us. It has had impacts in large, small organizations, and we're now working with micro-organizations to be able to implement that within their workplaces. So the advantage of the standard being voluntary, it means it can be adapted to each workplace. There are also challenges associated with that, and we'd be happy to discuss those as well.
Well, we're over time here, but I do have to ask you, Michel, before we go. I mean, our mutual friend, Dr. Heather Stewart out at Queen's, and others have talked about how attitudinal change will only get us so far when it comes to behavioral change, right? It's great to make the business case and the moral case, but as long as it's voluntary, then we're not always gonna change the whole picture. So, just briefly, do you think that the national standard should in fact be mandatory, similar to other safety standards?
I think there's real value in exploring that, particularly when it comes to policies, to ensuring that people are trained so that you create some of those baselines. So to create psychological safe work cultures, you need to have policies in place. You need to have employees trained. You need to have employees trained and ready to intervene should there be someone who is in crisis at the workplace, just like you have physical health and safety. You need to have psychological health and safety. So I think there are components of the standard that certainly would have value in being mandated within workplaces.
Michel Rodrigue is the president and CEO of the Mental Health Commission of Canada. Thank you so much for joining me, Michel.
Thank you, Mark.
Well, that's all the time we have for today. Thank you very much to Amy Kennedy, Ben Miller, Mary Giliberti, and of course, Michel Rodrigue for coming on and having such an important conversation about the policy aspects of health and well-being. Please make sure that you subscribe to the Living Well podcast for LifeWorks. We're on Apple Podcasts, Spotify, Stitcher, and everywhere else. You can also watch us on YouTube and on social media platforms. You can follow me as well at Mark Hennick. That's at MarkHenick. Thanks for listening and watching Living Well. I'm Mark Hennick. We'll see you next time. Take care and be well.